In the 2019-20 confidential review of maternal deaths, 19% of maternal deaths were due to suicides, and that's an alarming figure. So, what is mental health? It is not just the absence of disease or infirmity, but it's a lot of other things which is called as positive mental health. And what makes people more vulnerable to mental health problems? Individual psychological and biological factors like the emotional skills that you have, substance use, and genetics, which is an important factor, as well as psychosocial adversities. And what are the protective factors for a good mental health? Our individual social and emotional skills, positive social interactions, education, work, safe neighborhoods, and community cohesion. And the paradox is that most people do not develop a mental health condition despite exposure to risk factors, and many people with no known risk factor still develop a mental health condition. This is in general. Mental health disorders are twice more common in women than in men. And it is mental health problems in the perinatal period is a major health issue because of its devastating consequences on the mother and the child. Why are we concerned about perinatal mental health issues? Maternal mental health problems in low and middle income countries are under-recognized and under-treated, and therefore there is a lot of scope for improvement in this area. Adverse obstetric and pregnancy outcomes, including preterm births and fetal growth impairments, are caused by maternal mental health issues. Severe mental illnesses can cause increased risk of preeclampsia, antepartum and postpartum hemorrhage, abruptio placenta, and stillbirth. And as far as the infants are concerned, low birth weight, preterm birth, and delay in psychosocial development are caused by maternal mental health issues. Maternal postpartum depression in a study conducted in South Africa can lead to adverse psychological outcomes in children up to 10 years down their life. And of course, maternal mental health issues can cause difficulties in bonding between the mother and the child. And for some situations which are unique to India, India is a collectivist society where there is a lot of emphasis on collaboration and cooperation among the family members, and it is a patriarchal society, and there is a strong preference for male child, and there's quite a lot of female infanticide in India, may not be in Kerala so much. Dowry is another hazard which causes a lot of emotional problems and intimate partner violence in households. The overall estimate of the prevalence of antenatal common mental disorders was 22% in a systematic review and meta-analysis conducted in 2020. And the significant risk factors for common mental health disorders in women are negative reaction of husband or in-laws to the dowry, as per this systematic review, difficult relationship with husband and in-laws, lack of support or intimate partner violence or domestic violence, feeling pressured to have a male child. And of course, there are protective factors also like education, employment, having a supportive husband, and opportunities for recreation in pregnancy. And that means there is affluence also plays a role in protective mental health. Coming to the perinatal mental health issues, I would like to divide them into new onset mental health disorders in pregnancy and postpartum, pre-existing psychiatric conditions that may relapse during pregnancy and postpartum, and mental health during pregnancy, the overall mental health. Coming to the new onset mental health disorders, the most common one is postpartum blues. 50 to 80% of women experience this. Starts by day 3, peak by day 5, and it gets over by day 10. And the most common symptoms are emotional lability, mood swings, irritability. And it's a transient phase, it ends over a period of 1 week. But about 20% may go on to develop postpartum depression, and therefore we have to be quite vigilant. And we have to check for anemia and thyroid disorders in such patients. And how do we manage them? Psychoeducate about this condition, validate, acknowledge the issues, support them, and monitor for whether the person goes for postpartum depression. Perinatal mood disorders, it's quite important. The prevalence in India is 20% as per a systematic review and meta-analysis conducted in 2017. Antenatal depression is considered a risk factor for postpartum psychological morbidity, and all these enhance the risk of self-harm in the mother. Postpartum depression mostly is a bipolar disorder, and therefore when we are giving antidepressants to such women, we have to be careful whether these women can switch into the opposite polarity of bipolarity, because most of them can go in for bipolar depression later. And psychotic depression in the immediate postpartum period, you have to consider the possibility of bipolarity. Bipolarity means mania as well as depression occurring in different phases. Risk factors for depression occurring in the postpartum period includes a history of mood or anxiety disorders, stressful life events, poor social support, and domestic violence, and sleep and circadian rhythm disruption. And this is quite common in the postpartum period, sleep and circadian rhythm disruption. And this can precipitate a manic episode, as is usually seen in the general population as well. And in the pregnancy also, the same risk factors operate, except for unplanned or unwanted pregnancy and present or past pregnancy complications. This can add on to the risk factors in pregnancy. Coming to postpartum psychosis, as I had told earlier, essentially a postpartum psychosis is a bipolar disorder. The symptoms can be a manic phase, and usually it's the mixed phase with depression, anxiety, perplexity, that is extreme degree of anxiety, and usually it is a kaleidoscopic kind of presentation, a mixture of different kinds of presentation. Psychotic symptoms and mood lability is quite common. And we have to check for the possibility of a delirium or stupor in such patients, because delirium means a fluctuation in the level of consciousness and disorientation to time, place, or person. Many of these women seem to be disoriented as well. So you have to check the possibility of delirium and stupor, because cerebral venous thrombosis can also occur in the immediate period after delivery, and this is not very uncommon in India. Again, in postpartum psychosis, we have to be careful of delusions. And sometimes these delusional beliefs can be dangerous, and the women can even think of harming the baby. And in such cases, it is essential that we separate the mother and the baby for the safety of the baby. Risk of suicide and felicide, that is killing of the infant, can happen, and if the mother survives and the baby is dead, it can amount to homicide with its attendant legal complications. So we have to be extremely careful, and we should not be neglecting this issue. Now, what is the neurobiology of postpartum psychosis? Immune dysfunction is an important thing. Women with preeclampsia and autoimmune thyroid disorder have an overrepresentation of postpartum psychosis. So this points to an immune etiology. And immune disorders like postpartum thyroiditis, rheumatoid arthritis, and multiple sclerosis are exacerbated in the postpartum period, just like as the postpartum psychosis. And also diseases like anti-NMDA receptor encephalitis. The symptoms in anti-NMDA receptor encephalitis and postpartum psychosis can have similar attributes. So this points to immune etiology. And again, inflammatory etiology and involvement of hormones are also thought about in the genesis of postpartum psychosis. Anxiety, fear of fetal loss, especially in those with a history of infertility, IVF, miscarriage, or stillbirth. Some women have feelings of inadequacy as a mother. Anxiety of parturition, which we call as togophobia, and obsessive compulsive disorders can also occur for the first time in the pregnancy and postpartum, or there can be exacerbation of symptoms. Drug abuse, with women equality being talked about. Even in the case of substance use, there is a lot of equality happening, and there's a lot of alcohol abuse also happening in women as well as other substances. Remember that alcohol is a teratogen, and it can cause premature labor, abruptio placenta, stillbirth, and of course the fetal alcohol syndrome. So we have to inquire about the use of alcohol in women. Personality disorders, emotionally unstable personality traits and personality disorders can also cause a lot of problems in the marital life, and whether these factors contributing to intimate partner violence should also be thought about. Maternal suicide. Maternal suicide is one of the leading causes of mortality in the first 12 months after delivery, and as I had told earlier, 19% as per the Kerala statistics, the maternal deaths were due to suicide. This is really an alarming figure. And the causes of suicide can be considered in as a biopsychosocial model. Biological, psychological, and social factors operate. It is not just one factor which tips the balance. It's a conglomeration of all three. And when I say biological, genetics is involved, and also other biological factors like a decrease in the level of 5-hydroxyindolacetic acid in the CSF of patients. And social factors which contributes to suicide are social isolation, especially due to the pandemic which we had seen recently, media reporting, how the media glamorizes suicide and acknowledges suicide as a way to reduce the stress and problems. Suicide contagion. If one person commits suicide, it acts as an instigation for others as well to commit suicide. That is what is called as copycat suicide. Availability of methods which makes it easier for people to commit suicide, unmet mothers, cultural factors like dowry and religion, alcohol use in the spouses and intimate partner violence, all these can lead to suicide. But remember, it's a biopsychosocial model and several factors operate in contributing to suicide. Marriage and mental illness. Many people think that marriage is a cure for mental illness, and many women conceal about mental illness, especially major mental illness like schizophrenia and bipolar disorders. They are concealed from the spouse and the spouse's family, and they enter into marriage, stop medications, and relapse. And there is stigma and conspiracy of silence which prevents the women from revealing revealing that they had a past history of psychiatric disorder, especially major mental illness. And there is a blame game. Patients in remission. And when sometimes patients come to you in remission, it's very hard to know whether they had a past psychiatric disorder. Unless the woman says that they had a psychiatric disorder, it's very difficult to decipher. So they act as though nothing has happened, and this can contribute to relapses. So obstetricians can very sensitively inquire and very confidentially inquire about the presence of mental illnesses and whether they had been on any treatment before and act accordingly. Postpartum grief. It follows the death of the fetus, newborn, or birth of a child with congenital malformation. That also causes grief. Grief over the loss of a normal child, and that cannot be underestimated. And this leads to shock, numbness, grief, and grief hallucinations. How do we handle this? Honesty and openness about the problem, empathy, and sensitivity. And when a woman who has lost her newborn child says that she wants to see the baby, definitely she should be allowed to view the baby and say the last goodbye. You should not be preventing that. And give a dignified burial to the small infant. Screening for mental health disorders. Are formal screening programs for maternal depression viable? Is it okay? Is it cost effective? Of course, there are debates about whether it is okay or not okay, or whether it is feasible or not feasible. But what we have to understand is that any woman coming for a checkup should be, the mental health of the woman also has to be considered. And screening tools may or may not be applied. But remember, screening tools may sometimes overdiagnose or sometimes miss the diagnosis, or sometimes they may not meet the threshold of diagnosis. So this has to be considered, and a comprehensive mental health evaluation may be offered to women whom you feel require it in a very sensitive manner. And this is the monograph by Kerala Obstetrics and Federation of India. And this is a very must-read book. And according to this, primary care screening questionnaire for depression, and that can be administered by ASHA workers. And screening, all these points have to be considered while you screen women for mental disorders. And now coming to pre-existing mental illnesses. Pregnancy is not protective. And pre-marriage counseling, especially for women who have had major mental disorders, how they are going to carry out the marriage and how they are going to reveal that they had taken medications, pre-pregnancy counseling, and whether the medications need change considering the teratogenicity, and liaison between obstetrician and psychiatrist is very important. Overall mental health promotion in pregnancy. In low and middle income countries, we can consider psychosocial interventions being delivered by special healthcare workers and peers, and not just psychiatrists or obstetricians per se. And locally developed programs like thinking health programs, just a few seconds, have already been developed. And inclusion of maternal mental health in the policy and programs can be considered. And remember that half of the pregnancies are unplanned and that can lead to crisis. And Thinking Healthy, and this is a free book which is available on the net. You can have a read about it. And how do you train the woman to think healthy? And beautifully they have spoken about that, and I can help you with that later if you need. And relaxation techniques. Sleep and mental health is a very important aspect to be considered. And some tips for obstetricians, as my last slide. Be mindful of the mind behind the body and the belly. Active listening to the woman, empathy and sensitivity, validation of the issues, linking with family members and other specialists, clearing misconceptions to the family members. Psychiatric disorders are medical disorders with morbidity and mortality, and wishing them away will not make them vanish. They are treatable effectively and should be addressed. Thank you for the patient listening, and sorry for overshooting the time. Thank you.